So I'm going to be talking about PEG placement option for patients with advanced dementia associated with dysphagia. Is it a good idea or not? Okay, so I'm a specialist in family medicine, both from Canada and Israel, and I ran a home hospice for 10 years. Presently, I work in 3 nursing homes. One is on a kibbutz in the Western Galilee, and that's where I'm going to be taking my cases from. Dementia is a growing concern for societies globally as people live longer. About 90% of individuals with advanced dementia suffer from eating problems, which contribute to their general health decline and weight loss. So the alternatives aren't great. One is to continue with oral feedings as best as possible. 2 is to insert a nasogastric tube, which is usually only a temporary solution. And 3 is to perform a surgical procedure inserting a permanent feeding tube, percutaneous endoscopic gastrostomy, which is termed a PEG. So those who are in favor of PEGs believe that it reduces weight loss, it sustains nutrition, and reduces the suffering associated from dehydration and malnutrition. But even if this is true, it doesn't prevent the continuing cognitive decline. But the vast majority of evidence suggests the opposite. Numerous studies have shown that tube feedings neither reduce mortality nor improve morbidity. And there are many comparison studies. One 8-year study of almost 37,000 nursing home residents found that PEG feedings, regardless of when they were inserted, did not improve survival. Another study, 18-month study, found that survival was actually shorter in the PEG-fed group than the group fed orally. And in another study, 54% of people with PEG died at 1 month and 90% at 1 year. And another study, again, showed that those with a PEG didn't live longer than those without a PEG. Well, what about morbidity? Well, one of the concerns about people with a PEG is aspiration pneumonia. However, it's also a significant complication of tube feedings and frequently is the cause of death for people with PEGs. Pressure sore improvement. Prospective study found that with 88 elderly demented patients, a tube feeding showed no beneficial effect on nutritional outcomes and failed to promote healing of pre-existing pressure sores compared with oral feedings. There are also sequelae of feeding tubes. One study found that 20% of people with feeding tubes had to have them replaced or repositioned during the 2 years of the prospective follow-up. That, of course, means frequent visits to the emergency room. And 30% of the demented patients needed at least 2 replacements, with the mean survival time after replacement only 54 days, which isn't very long. Now, the natural history of the dying process is that people with advanced dementia may decline to eat or drink as they approach the end of life period. And refusing food and fluid is a normal part of the natural dying process, particularly as the body slowly shuts down. And regardless, one must appreciate that the central problem is dementia, and the feeding difficulties are a complication. So even an effective feeding tube doesn't prevent advancement of dementia. So even if the feeding tube is successful and the resident lives longer because of it, their dementia will advance, usually to the point that they don't recognize families, they don't talk, and they're minimally connected with their surroundings. And that only gets worse in time. The literature consensus overall backs what I've said. A Cochrane systemic review showed no improvement in survival, quality of life, nutritional status, function, behavior, or in psychiatric symptoms in patients with advanced dementia receiving tube feedings. And the American Geriatric Society position paper is almost the same, and it recommends oral feedings, which avoid the burden and complications associated with tube feeding. So if we look at it schematically, when you have a feeding tube, you have complications, the same complications that you have without a feeding tube, plus complications of the feeding tube. And it doesn't improve mortality. And the dementia progresses anyway. And even if there aren't complications, it doesn't improve mortality and it doesn't stop the progress of dementia. Nevertheless, insertions of feeding tubes is common. In the United States, a cross-sectional study involving 186, almost 190,000 nursing home residents found that 34% of the residents with advanced dementia in the nursing home did have feeding tubes inserted. So why the discrepancy? And the discrepancy probably is due both to family pressure and healthcare workers' views. So one reason is misinformation. Many family members and caregivers believe that not eating adequately is synonymous with suffering from hunger or being food deprived. That's despite the fact that losing weight is not, at the end of life, is not synonymous with being hungry. And there are often unrealistic expectations of feeding tubes. A lot of family members view its intervention as high quality care to address the feeding problems. One study said that surrogates' expectations found that 79% of people believe feeding tubes would improve the patient comfort, 87% anticipated better quality of life, and 56% thought that it would provide better independence. The facts don't bear out these expectations. And a belief system. Religious beliefs may associate tube feedings with manifestation of respecting the sanctity of life, regardless of its quality or the artificial means necessary to maintain it. And then there's fear of contributing to starvation. Some family members have the impression that they will directly contribute to their loved one's starvation if they fail to support the feeding tube option. And finally, emotional and cultural issues. The cultural background and ethnicity of families often play a significant role in the discussion with healthcare workers. The medical system can also be problematic. Some institutions, I'm going to be presenting a case like that, encourage or even insist on PEG insertion for residents who have dysphagia. So I'm going to present 4 cases, and after this presentation, the cases that you'll see interviews with these 4 patients. The first 2 are with PEGs. The interviews are with the daughters of the people who had PEGs. The first 2 had PEGs. The last 2 are with oral feedings. And in the very last case, the resident itself is still alive and living in the nursing home. I was the active physician in all these cases. So the first case I'm going to present is Judith, and we'll be interviewing her daughter, Gila. She was in our nursing home for almost 9 years. She was 92 at her death. She had been born in Romania. She was a Holocaust survivor. She had numerous, in addition to her medical problems, she had psychiatric problems, PTSD from her Holocaust experience, depression, and dementia. But her main problem was dementia. And by 2015, she no longer recognized family members. She was transferred to our institution. Her daughter couldn't tolerate the idea of her mother not eating, nor tolerate the idea of her mother dying. So she insisted on having the PEG procedure. That was before I began working at the nursing home. Remarkably, this woman did very well. She was with the PEG for almost 8 years, and she only lost 6 kilograms during that stay. In retrospect, her daughter and the family don't regret their decision, but over the years, many times I encountered her with second thoughts. She had great difficulty visiting a mother who did not recognize her and wasn't connected with her surroundings. The second case is Sarah. I have 2 Sarah cases, so I call this Sarah 1. Also with profound dementia. She was 83 at her death. She was with us for from May 21 to August 22, so about a year and a half. She had profound dementia. She had medical problems. In 2021, she had a severe CBA, which left her with left hemiparesis and very difficult swallowing problems. She was hospitalized. She couldn't tolerate the NG tube, and she was transferred to our care. She had relentless weight loss. If you look at the table on the right, you see that every month she lost a few kilograms. And between her admission date and the date that she died, she had lost over 16 kilograms. All we could give her were subcutaneous infusions. At a certain point, the family just couldn't tolerate the progressive weight loss and insisted on a PEG. But she died 2 months after having the PEG. Even though her weight stabilized, she had a pressure sore which didn't get better, and she died 2 months afterwards with a fever-related illness. The third case is Esther, and her daughter was Orly, and she was a resident for a short time from July to September. She was 87 at her death. When she was younger and healthier, she had signed an advance directive and was opposed to any artificial interventions. Then she went on to develop dementia, and then she had a severe CVA, which left her almost in stupor with hemiparesis and with severe dysphagia. She couldn't tolerate an NG tube. She was in an institution that insisted that if she wanted to stay, she had to have the PEG. So the family contacted me, and we transferred her to our nursing home, and she was given subcutaneous fluids and whatever food that she would eat. She held on for 2 months. The family was relieved and grateful for the non-invasive approach to her care at the end of her mother's life. And the final case is of a woman also called Sarah, whose daughter is Orit. She was admitted in December of last year, 89 years old. Prior to that, she had lived at home with 24-hour care. She had profound dementia and agitation, but she actually ate. Then she was hospitalized because of sepsis, and she almost died. She was discharged to our nursing home with breathing and dysphagia and an NG tube. She was mostly unresponsive, and she was basically discharged to die at the nursing home. 3 days afterwards, we took out the nasogastric tube, offered her food, and she began to eat small amounts. And also her mental situation slightly improved. She became more alert, she was cooperative, and at times she would even recognize the family. So she's been with us since December, and she's lost a little over 2 kilograms. The family appreciates the nursing home approach for caring for their mother. So in the first case, a PEG was done because the daughter could not tolerate her mother not eating or dying. It lasted for 8 years, but much of that time she was in a vegetative state. In the second case, the weight loss was relentless, and after several months, it became intolerable for the family. And while her weight did stabilize with the PEG and the family was relieved, she nevertheless died within 2 months of the procedure. In the third case, she had signed an advance directive against artificial intervention. Her terminal situation was such that she had no chance of improvement anyways. Her wishes were respected. And in the fourth case, the siblings were adamant that their mother should be left to choose to eat. And fortunately, once the NG tube was removed, not only could she eat somewhat, but her mental and emotional state improved. So why the gap? Why is the literature so much in favor of a PEG, and nevertheless the procedure is so frequent? I think it's because one of the reasons is because the provider's perspective is different from that of the family, in that it's less emotionally charged. For the family, the deliberation cannot simply be reduced to what is statistically preferable. There are value issues that have to contend with. Furthermore, for the family members, it's not simply a decision, it's a process that they must undergo. Tremendous back and forth talks, lots of talks within family, lots of questions. Concerns regarding starvation and possible preventable weight loss seem to often take precedence over the knowledge that the dementia will continue to advance. However, later on, those same families who who wanted the PEG in order not to prevent starvation may struggle with caring for a patient who's disconnected and no longer recognizes them. I think that one should take an approach of one size does not fit all. The healthcare team should work with the family to reach the decision which best suits them. So now I would like to ask the coordinator to show the film, the interviews themselves. These are edited interviews with the four daughters. It's about 8 minutes. So can you go ahead and show the video, please? Want to ask questions in the meantime?
It's Pablo talking. Thank you for the presentation. I am a geriatrician in Spain, and yeah, firstly, I think your presentation should be given in different congresses because yeah, it's very clear, and I think that yeah, nowadays in this congress we talk about nutrition and metabolism, and there's no reason to perform endoscopic gastrostomy when dementia is advanced, because nutrition is not a question just of intake nutrients, is more. And also in my years of experience, I have never performed an gastrostomy, but I saw a lot of patients with them, and I saw a lot of old people with dementia dying due to a pneumonia, seeing that they are just dying because of pneumonia, infectious, and yeah. But my question is, what we should we do to concern families about this? Because sometimes family thinks that you know, lifespan is the main goal, longevity, and we have to maintain life expectancy despite of suffering. And how would you recommend to deal with families?
Okay, that's an easy question. The answer I don't think is easy. I think it takes time. I think you have to have repeated conversations with the family. You have to provide information for them, not wait until you don't have a choice and then go ahead with it. Share the data, discuss the alternatives. Sometimes you need to have a family conference. My way of working when it works out is often there's one family member that I mostly talk with and they talk with the rest of the family. But sometimes you need to have the whole family together. And part of it depends on how you define your role. If your role is as a physician, then you decide. If your role is in part a facilitator, then it may mean that sometimes you agree to decisions which are not your priority. And so I think to a certain extent, it also depends on the physician's approach. I guess and of course, if you provide good caring care, then they'll be less prone to want to go for a PEG. But I think that the implication of your question is it's pretty obvious that they shouldn't have a PEG. But when you're dealing with people who see their loved ones losing weight and not eating, it causes terrible distress. And it's very hard to use a rational argument to convince them otherwise.
Yeah, thank you. Thank you.
שלום גילה, אני מודה לך שהסכמת להתראיין היום. אני מבקש שתספרי קצת על איך הייתה אימא לפני שהיא חלתה.
אימא נולדה ב-1931, ילידת רומניה, הגיעה לארץ בשנת 48, היא הייתה ניצולת שואה. התחתנה בשנות 50, חיי משפחה רגילים, מאושרים, טובים.
ספרי לי בבקשה על ההידרדרות שלה, עם הקשיי אכילה שהובילו להחלטה להכניס לפג.
אחרי זמן מסוים חלה שוב איזושהי הידרדרות משום מה. היא הייתה חולה, היא אושפזה אפילו בבית חולים, וזכור לי שבבית חולים נאמר לי שהכניסו לה זונדה, היא התנגדה לזונדה והכניסו לה אותה בכוח. הבנתי שעם הזונדה אנחנו גם לא נוכל לתת לה את האפשרות הזו שיכניסו לה כל שבוע או שבועיים, משהו כזה, זונדה. ובסופו של דבר החלטנו יחד, אחי ואני, שאנחנו הולכים לפג.
מה המחשבות שלך בקשר להחלטה להחדיר לפג?
בדיעבד, אם אני מסתכלת אחורה, וגם לאור מה שאחי ואני החלטנו, הבנו שפג זה עניין מלאכותי, שיכול להשאיר מישהו בחיים. במשך 5 שנים הראשונות, בסך הכל ידענו שאמא מרגישה טוב, גם שאלתי אותה כל פעם אם כואב לה משהו, לא נוח לה, לא טוב לה. בתחילה היא הייתה נוגעת בזה, ואחר כך היא פשוט, זה היה חלק מובנה ממנה.
שלום ענת.
שלום.
ספרי לי קצת על עצמך ועל אמא לפני שהיא חלתה.
אמא שלי, שרה גונן, ירושלמית כמה? סביב ה-60 שנה של חייה מאז גיל 20, נולדה בחיפה. עבדה כספרנית, כמנהלת ספרייה באוניברסיטה העברית, הייתה בן אדם מאוד מאוד פעיל, נמרץ. בסביבות גיל 75 שלה, כנראה שהתחילה איזושהי הנמכה קוגניטיבית, שהיה מאוד קשה לזהות אותה. היא התחילה כבר לגלות סימנים של קושי בבליעה.
מה הביא להחלטה של החדרת פג, ההתלבטויות שלכם?
כמה חודשים טובים שהיא הייתה פה, אכלה מעט מאוד, זאת אומרת בלעה מעט מאוד, אבל עדיין שמרה על איזשהו משקל יציב, ואז התחילה גם הירידה, היותר משמעותית. אבל כן, היו הרבה התלבטויות, והייתה בסופו של דבר קבלת החלטה, שאני חושבת שבאמת, כמו שאמרתי, הייתה סביב האיתותים שאימא שלי העבירה. היא העבירה איתותים של אני עדיין רוצה לחיות. זוכרת עצמי אומרת לך, אני מכירה אותה טוב. אני מזהה שהיא אומרת, תנו לי עוד קצת אפשרות להתמודד.
אמא חיה כחודשיים אחרי שהכניסו לפג. איך הייתה התקופה הזאת בשבילך? וגם תספרי קצת על הליווי של הצוות, בבקשה.
בעצם אני חושבת שקודם כל הייתה תחושה של רווחה אצלי, במובן הזה שידעתי שהיא מקבלת מזון, שהגוף שלה מקבל מזון. הצוות פה כן הקפיד לייצר את האינטראקציה הבין-אישית איתה, גם כשהיא הייתה מקבלת את המזון דרך הפג, אם זה היה לנקות אותה, ואם זה היה לדבר איתה, או להניח יד. התפקיד שלך בתוך הדבר הזה, בתוך הסיפור הזה, והתהליך היה מאוד משמעותי. כמו שאני אומרת, בהסתכלות אחורה, אני חושבת שזה היה הדבר שכן היה נכון עבור אמא שלי, עבור הסיטואציה שאמא שלי הייתה נתונה בה.
שלום אורלי.
שלום, שלום.
ספרי לי קצת על עצמך וקצת על אמא כשהייתה בריאה.
אמא הייתה מאוד מאוד דומיננטית, מאוד עוזרת לאנשים, מאוד נדיבה, מאוד אומנותית.
ובהמשך היא הגיעה אלינו.
אז בעצם היא הגיעה אליכם באמבולנס, אחרי שבעצם בבית חולים הגריאטרי אמרו לנו שאם אתם לא מסכימים לפג, אז אתם מסולקים, ואז אנחנו בעצם יצרנו קשר איתכם. ופה פגשנו באמת מה שכל משפחה זכאית לו בסוף ימי ההורים. זאת אומרת, מקום מבין, מקום מחבק, מקום שיודע לתת אלטרנטיבות. וכל דבר, כל התערבות, תמיד התייעצת, תמיד שאלת, תמיד הסברת. ובאמת, הרגשנו שאולי זאת התחנה האחרונה באמת, אבל זאת תחנה מחבקת מאוד ומאפשרת סיום בכבוד, כמו שאימא רצתה, בדיוק כמו שהיא רצתה.
שלום אורית, אני אתחיל בכך שאני אבקש ממך לספר קצת על עצמך ועל אימא לפני שהיא חלתה.
אימא שלי בת 92 היום, ממוצא תימני, אישה מאוד פעילה בעברה, והיום מאוד מוגבלת.
מה גרם לה להגיע לכאן, וגם מה היו קשיי האכילה שלה?
אימא שלי ביום אחד איבדה את היכולת לנשום כמעט לגמרי, ומצבה הידרדר מאוד, הגענו לבית חולים. היא אושפזה שם כשבוע, והחלטנו להוציא אותה משם לאשפוז בבית סיעוד עם מצב נשימתי לא פשוט. ובעצם נאלצנו לבצע החלטה. האם אנחנו מאפשרים לאמא שלי את יכולת ההחלטה לבחור מתי היא אוכלת ומתי היא לא אוכלת, או שאנחנו לוקחים אותה לניתוח ומכניסים לה בעצם לא מאפשרים לה יותר להחליט בעצמה. אנחנו 4 אחים, זאת הייתה החלטה משותפת, ובחרנו לאפשר לה להחליט בעצמה.
ומה קרה מאז שהיא הגיעה לכאן?
בערך 3 ימים אחרי שאמא שלי הגיעה לבית סיעוד, אנחנו החלטנו בהחלטה משותפת איתך להוציא את הזונדה ולאפשר לה אכילה עצמאית, והיא אוכלת. היא אוכלת לבד, היא אוכלת מעט, אבל היא אוכלת כמה שהיא צריכה וכמה שהיא בוחרת, אבל אכילה עצמאית לחלוטין מתוך בחירה שלה.
ומה מצבה?
אנחנו רואים שהיא ירדה מאוד במשקל, אנחנו רואים שהיא נמצאת במצב של תת-תזונה, אבל עדיין היא מאוד רגועה. היא לפעמים מחייכת, היא מתקשרת, והיא אוכלת בדיוק כמה שהיא צריכה, ואנחנו שמחים עם מה שיש.